back to another episode of Pod Patrol with your host, Dr. Jeff Dikis. Tonight, I am joined by Dr. Priya Parthasarathy. Thanks for joining me.
Thanks for having me. I'm really excited to be here.
Did I get your name right on the first try?
It was perfect.
Oh, let's
Perfect. And thank you
go.
for not saying Dr. Priya or Dr. P, as most people refer to. It's a tricky one.
They bail out. They don't go for it. I did. Thank you for joining me. I see you everywhere. So you've got some involvement. We'll touch base on all the things that you're involved in. But let's start back with how you kind of came to find podiatry, because you have kind of a unique story. Why don't you tell us how you kind of came to find podiatry and where you are now?
Absolutely. Yeah, I do have a unique story into podiatry. I'm actually Canadian as well and grew up in Toronto. Right out of high school, I got into a 6-year program between Canada and the possibility to go to a podiatry school in the US. So in Canada, they have a very different podiatry model, especially the province that I came from, Ontario. We have chiropodists there that are conservative podiatrists, but their the profession is chiropody. So I actually did 2 years at the University of Waterloo to do my undergraduate, and then went to chiropody school for 2 years. Then I applied into Temple University and got credit for my first 2 years and transitioned into the 3rd-year class.
Interesting. And was that pre-planned, or did you kind of decide to change after you'd already enrolled in school in Canada? Or this is all like preset and predetermined?
This is all preset, but the Temple University portion you have to get into. So that was very challenging because I had to take equivalency exams to get credit for all of the basic sciences. And then as soon as I got here, I had to pass my boards right away, which was an absolute shocker because, in Canada, there aren't many standardized tests and things like that. It was very challenging, and the program no longer exists.
Okay.
So at Temple, I had 2 people that were the year ahead of me that were doing it, and then 2 people in my year. And there was 1 student after me that came from Canada as well. And then that's it, because you have to really maintain a certain average. And a lot of people got X'd out, right? Trying to do undergrad in 2 years was difficult.
Yeah, I bet. Is the goal for people doing that program to come to the US, get better training, and then go back to Canada? Or is it always to come here and stay here? Does the training transfer back to Canada in any way?
Yeah, that's a great question. It's very dependent on the province. So in Ontario, the borders are closed to US podiatrists. You cannot take an equivalency exam or anything like that. However, people have gone back to other provinces like British Columbia, Alberta, where they're able to really practice, to the extent of our training. It's still different there. It's harder to get OR time in hospitals. So a lot of them have private surgical suites, and they get a lot of volume because the wait list in Ontario sometimes is up to years to have a bunionectomy done. So there are podiatrists practicing there, but they were previous to when they closed the borders.
I see.
So that was tricky. So I was still planning to go back to a different area in Canada, or a lot of people practice in border towns and, in Buffalo or Michigan. I just did my residency in Michigan too. But I met my husband in podiatry school and I never went back.
Plans change, don't they?
Yeah, they really do. And it was really cool. I went back 2 weekends ago to lecture in Canada about my topic was like diabetes is more than neuropathy, and just giving them like the whole picture of what podiatrists do in the US and how critical prevention is. And it was really awesome to go back. It kind of came back full circle to lecture internationally.
That's awesome. As far as being a podiatry couple, obviously I am a podiatry couple as well. So I kind of know the answer to this, but I think anybody listening to this would be interested to hear your point of view of what that's like, because you meet in school and then you don't kind of think 6 steps down the road of the kind of hurdles that come from residency. And do you want to go to the same place? Do you not want to go to the same place? So what were your guys' thought process on how you wanted to handle residency and job hunting thereafter?
Yeah, yeah, it was challenging for us, especially because when I was here, I wasn't a US citizen. I also wasn't on a green card. So I had to find a hospital that sponsored an H-1B visa
Mm.
so I could work at that hospital. And before it was many, many residencies. And that's what I talked to a lot of different students about and residents about to really figure out if they will sponsor that visa. And that was challenging for us. We wanted to match in the same space. We were, kind of decided that, okay, we're going to get married.
Yeah.
And so we ended up in Michigan. And
Mhm.
Michigan was not my initial thought. I actually switched a lot of externships over to Michigan later. Because
Mhm.
I mean, come on, I'm from like freezing cold Toronto. I was like, California, Florida. And like, yes, I know I should be picking residencies based on quality and all that kind of stuff. But,
Yeah.
you know, was looking at geographical area too, but it was much easier to match together in Michigan because there was
Sure.
plentiful programs.
Yeah, lots of programs there.
Yeah, exactly. And so that was challenging. It was challenging to be a Canadian student finding a residency program as well, and then the job hunt, right? As you went through as well.
Uh-huh.
What was nice for us, though, we really were not tied down to a geographical area because he was from Michigan, and I decided that, like, I kind of wanted to go somewhere with seasons, but something a little different. So we were looking at different areas. So at least that helped us in our search, but we knew we wanted to be at different practices for sure.
Yeah, absolutely. Let me go back for a second because I'm interested. When a hospital has a, I don't remember the letters. It sounded like H1N1, like a flu strain, but it was
H1B. Yeah.
H1B visa. What does that entail? Do they have to like pay for that, or why do some sponsor, some don't? What does that mean?
Right. There's a lot of different stipulations, and it may have changed now because I finished residency like 13 years ago. But there's only X amount of H-1B visas. You can only have X amount of residents on that H-1B visa, and yes, they have to pay for it.
Mm,
So that is different, and so that's why it's really difficult for foreign medical grads in general to match into different residencies and things like that because those H-1B visas are limited. There's other visas that you can get, but you have to go back to your home country
mm,
afterwards.
mm,
So that's a little different as well.
mm. When you guys were looking at residency programs, did you consider trying to match to the same program, or from the get go you thought, no, we want to be kind of on our own, doing our own separate thing? Because we had a difficult time trying to figure out what we wanted to do. We ended up at the same one, but it was a big program, so it didn't really overlap as much. But what were you guys looking for in terms of residency?
Yeah. Interestingly enough, we didn't even tell anyone we were dating.
Hmm.
So we kept it completely, completely separate.
Mhm.
I have my different motivations for that. I left Canada, came to the United States. I really wanted to match into the program that worked for me.
Mhm.
Um, and I didn't want any biases or anything like that. Not to say that that happens because there was actually a married couple in my residency program.
Okay.
So we ended up, kind of just doing it completely separately. But we just realized that there was a lot of programs in certain geographical areas.
Yeah, that makes it more likely that you would match nearby.
Yeah, exactly.
Spinning that fast forward to job hunting, because again, we lived it. It can be difficult to find two good jobs that don't overlap too much, but aren't spread out too much in a certain geographical area. So, why don't you talk about what you guys were looking for when you started looking for jobs and how that process worked?
Yeah. So, luckily in the Washington, D.C. area, there are plentiful practices. There's so many different types of practices, hospital based and all that. And, coming out of residency, you're really unsure. But we have ended up time and time again, our practices are very far apart. And so my husband is, we live in Potomac and he drives all the way to Baltimore near where our colleague and our classmate, Jake Wines. He is around
Mhm.
there. And so it was tough to find something really close.
Yeah.
The other problem was it wasn't as big of a problem there, but there were a lot of group practices. So now I'm part of a private equity group that has like 345 doctors. I mean, that would have made it really challenging in our area to be in completely different practices.
Yeah.
So that we didn't really have to consider. And we were both looking for different types of practices. So I'm kind of, your podiatrist that does ev- everything at the beginning, did surgery, did a lot of peds. So I wanted more of like an all around practice where my husband, he went to Detroit Medical Center. So he was very like trauma heavy, surgery heavy. And that's why he ended up partnering with the orthopedic group. So that was also challenging, finding something that is, particular to your skill set or your, what you want to specialize in.
Sure. And have you guys been happy in that situation? I mean, we're not too different. My wife teaches at the school, and I'm in a multi-specialty clinic. So and we're pretty far apart. We're probably like an hour apart from each other. So we have zero overlap. We have no overlap in terms of daily basis or jobs or competing with for patients or anything that you might think of that could potentially come with that. Are you guys happy with that situation of being kind of separate but come home at the meet at the same point at the end of the day?
Yeah, and I think that's one advantage of working further away because in our area, it's completely different patient populations for us. So there isn't any overlap because our area, although there's many practices, it's very competitive, very
Yeah.
competitive. Your patient will go from different practices, and we really have not come across that except for the one patient where he operated on one side and I operated on the other. And we were like, what? We obviously disclosed it afterwards,
Yeah.
but she had moved and had just found me.
Yeah.
But that was one time in 13 years.
That's pretty
So,
crazy.
and that's worked out well for us.
Yeah.
Just for the competitive nature of so many practices being nearby, we don't have to worry about that aspect, and we're operating at different hospitals as well.
Sure.
So that's been helpful as well because sometimes I don't know, like you'll be in the OR and this happens to us, reps work with him, reps work with, me.
Mhm.
So it's funny because I'm always like, oh, I wonder what, how's my husband in the OR? Or like, wonder what they think about me in the OR and those types of things as well. So, but it's worked out really well for us.
That's not how your wife does it.
Yeah, exactly. Well, the biggest thing is, oh, your husband, he's quiet and he concentrates, and all I do is, dup, 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 So,
That's funny.
and I was like, that's how I concentrate.
Yeah, exactly. That's funny. Let me talk about the private equity because that's a hot topic in our field right now in terms of groups that have some sort of private equity involvement. How I assume that is something that transpired. It wasn't that way when you joined the group, but has since transpired over the course of you being a part of that group. Can you talk through that process for any of the younger people who kind of don't understand what we're talking about when we say private equity?
Yeah, absolutely. So we are no longer physician owned. We're owned by a private equity company. And so we are all employees now of this company. However, there are partners and then there's associates. So you're absolutely right. So when I started, many years ago, we had just started to form a smaller group. Okay. So I think it was about, I don't even know, maybe starting with 6 to 8 practices. And
Mhm.
then it grew larger and larger and larger. And then it was bought out by private equity. And
Okay.
then what private equity then did is made us a national group and went and, brought all the different practices. So it is a different model. Absolutely. Because we still can maintain a lot of independence in our group. We're still are different clinics, and we all operate differently and have different protocols, but we're still under the umbrella of the private equity group. So we have different regions, and they look at different things and different metrics. So for example, if you wanted to buy a shockwave machine, it's not my decision to buy that shockwave machine. And
Hmm.
so that has to be approved.
Sure.
So in that model was really different. And what was also different is I was an associate prior to us being bought by the private equity and then became partner. And so that's a very different kind of contract negotiation that I feel like a lot of people don't know about, because it's very different when private equity comes in and buys your group versus if you're the associate that goes with the group to the private equity group. So
Hmm.
that's when you really have to advocate for yourself. You have to ask the right questions and you have to decide if that's the right move for you. And I feel like a lot of people don't understand that because they think, well, well, my boss brought in here. It's like, no, no, no. You are all employees now of this private equity group. And maybe it's advantageous for you to actually partner in prior or, things like that. And those conversations are really important to have prior to that happening. And I feel
What?
like we don't know enough about this, as people have talked about previously. There's different models, there's lots of panels on those sorts of things. But like reaching out to a mentor when that happens or someone that's been through it is really important.
Yeah, I can imagine because anytime finances get involved in medicine, it murkies the water a little bit sometimes. Sometimes people have a fairly strong understanding of the financial component of what goes into medicine. Let's say someone who's in private practice and they're by themselves or has a small practice. Those people know how much money they made, how much money went out the door, how much came in, what their expenses are, what the rent is, all that stuff. Someone like me, I just look at the end of the month and I'm like, yep, looks good. All right, moving on. So, um, as far as understanding the financial components of that, I think that's a good point. And seeking out someone who's gone through that transition, that process would be beneficial to them. When you transition from associate to partner, what are the differences between those two in your group?
So in my group, it's, buying more equity into the group itself. And within our group, there are different committees and things like that you could be a part of. And you're more, I guess, more privy to the finances of the group and exactly what's going on.
Uh-huh.
That's changing now, transparency, all the employees, it's more transparent and things like that. But starting off, it was important, being a partner, being involved in those conversations. And like you said, a lot of people just check their numbers at the end of the month, okay, there we go. It's not good enough. It's not good enough. And especially when you're in larger groups and things like that, it is so important to look at the financials and make sure that everything is okay and really learn the ropes. And it takes so much time, but I've really dived into that and have been advocating for others to do that as well. So, having access to reports, making sure everything is okay, because mistakes are easily made, unintentional, but they really are.
Yes. And it can cost you a whole lot of money. I mean, I kind of jokingly say I check the number at the end of the month. But when my first 4 years of practice, I worked in an orthopedic group where I would get reports and they were very transparent and I would get all this information. But every now and then there would be a mistake. And, it doesn't seem like much, but a mistake now not caught could be thousands and thousands of dollars down the road. Wait, this isn't showing my DME. Oh, wait, this isn't showing my reimbursements for, billing for X-ray or whatever it may be. Oh yeah, okay, sorry, we'll fix that. Oh, okay, that's a lot of money that you would have missed out on if you just took their word for it and didn't kind of know what you were looking
Absolutely.
at.
And again, getting back to the business of podiatry that we do not understand. And a lot of people just send their billing out and, or it's handled by, I don't know, like mod med billing or something like that. You can still hold those people accountable, but you
Mhm.
got to come up with, figuring out what the right method for you to dive deep into that. Because especially with insurance companies these days and everything that's happening, and it's affecting everybody, prepayment audits, post payment audits, like you need to be on top of all of that. And not to think that like if you're just part of a big group that, you're like, oh, okay, that's it. So I think that's really important to remember.
Yeah, trying to find a mentor from that space, maybe senior residents who've been out in practice maybe a couple years ahead of you, who've been in those situations. It's hard to ask your colleagues like at the same practice because, sometimes people don't want to give away their finances versus
Yep.
someone else's, but finding someone else who's in a similar group, maybe a couple senior residents or some attendings back from your program would be good places to start. If you could list some positives and negatives from private equity, what do you think about private equity?
hmm So the positive is, like we're saying, tapping into mentors and colleagues, and we have an amazing group of doctors, really amazing group that you specialize in everything. So you have complete access to that right away.
Mhm.
And with private equity, you have more money backing you. So it's efficient billing, it's efficient EMRs. I just got brand new technology like, the butterfly ultrasound machine, shockwave therapy and things like that. And even if you don't have it in your office, someone else nearby could also have it. And you could use that office for, doing those types of things.
So
So I feel like you
essentially
just
essentially you're pooling resources is what you're saying.
Absolutely. So pooling resources and having more access to resources as well. I also think, like efficiency wise, you learn from other doctors and they adopt different protocols and things like that much easier. Because I feel like a lot of people just get stuck in what they're doing. And then you're like, oh, wait, I didn't even think that you could do it that way. So our group does have a lot of benefits. We put on CMEs. You can hear from other doctors and negotiating reimbursements because you're a large group. So all of that comes into play. And then the negative is you don't own your practice. Right. As I said, if you want something, you need to ask them for it. And that's a major shift for a lot of podiatrists that are in, private practice. And it's a hard transition for people that do sell their practice because you don't really know what that means until you actually do it. Right.
Right. Right.
And then also having, when we talk about efficiency and numbers and all that, sometimes you may think you need multiple MAs, but another practice is doing the same thing you are with less help. And so that sometimes is a downside too, because if you're used to a way of doing things, but they see a more efficient way of doing things may change. And it may not be a negative, but it definitely would change your day to day.
Maybe a little less autonomy than what you might be used to.
Right. Exactly.
So you mentioned there shockwave therapy. I think that's an interesting area that's kind of under discussed, maybe. Let's start talking about shockwave therapy and how you use that in your practice. How did you get started using it?
So shockwave therapy, I have a couple of mentors in our area that started using shockwave therapy and they were getting really excellent results. I also am part of the sports medicine group. And I have a lot of colleagues and friends there that have been using it for many different things, like things that you wouldn't think, sesamoiditis, neuromas,
Hmm,
and they were getting really good results with it. And so
yeah.
that's when I really dove deep into it and started using the shockwave. We get a lot of second and third opinions in our area. Again, talking about different doctors, orthopedists, podiatrists, and some people really want to exhaust all possible conservative treatment before going to surgery.
Yeah.
And that's when I started really introducing this regenerative therapy in general, and especially shockwave therapy, to these patients before they went to surgery as kind of a last resort. Initially, that's how I started.
Yeah.
Then I was like, wait a second, this is really getting good results.
Mhm.
Always tough. And this is, I lecture a lot on regenerative medicine as well. It's tough because it's not covered by insurance. So
Right.
you do have to be in a certain area to do this type of treatment, just because you may not get patients that would want or can afford to do it. But I was getting really good results. And so I increased it to more, chronic conditions like chronic tendonitis, Achilles and posterior tibial tendonitis, plantar fasciitis, and patients were getting better, and patients were getting better and getting long-term results. So it's an alternative to things like an injection. a steroid injection, for example, but again, the cost that's associated with it.
Right.
I lecture a lot about regenerative medicine, and it's so interesting that I get so many questions from residents and students about regenerative medicine. So I was just lecturing with the IPMSA with the Scholl School because they invited me because they really liked the lecture, and they say we don't get any of this.
Hmm.
We have one attending that sometimes does shockwave therapy, and a lot of people are really interested in it. So I feel like there's a little bit of a gap in our education there, that I had to go find resources and talk to other people to really be an expert, instead of it being taught to us.
Yeah.
And that may have changed in podiatry school now, but from what I got from the med students and residents, like they do not see a lot of it.
No, I think it's probably mentioned as a treatment option, but I don't think they dive much deeper than that. So
Right.
for the younger people and me, how does the shockwave therapy work?
So there's two types, radial and focused. And so shockwave therapy is sound waves that penetrate through, really good for chronic conditions. So there's studies out there, especially in plantar fasciitis, that the actual fascia itself thins out over long term. So there's a study that it's been over 1 year. The If you inject the plantar fascia, it's doing the same thing. So it's kind of reducing the inflammation, thinning out the fascia, but the results are short term. So they're
Right.
not long term. So it's a physiological change in the tissue itself. It also helps tendons and ligaments regenerate. So, for example, like a posterior tibial tendon tear or a peroneal tendon tear, of course, if they have a collapsing flat foot that needs a total recon, that's something different. But
Right.
your isolated small partial tear
Yeah.
with a patient that's not getting better, it has really made a big difference. And that's when, it's a very similar situation where you may also use PRP. The issue with PRP is sometimes people immobilize afterwards and sometimes people don't. With shockwave therapy, you don't have to immobilize afterwards. There's no downtime. I usually do 3 sessions. I always make sure that they sign up for 3, and we do it weekly. And so it's really important. And I always make sure that they know that the long term results from that can take up to 8 weeks to see improvement.
Hmm.
Um, but they seem to be significantly improved. So it's been working in even those cases in the MRI where there's like bone marrow edema, so there's like plantar fasciitis, like the calc lights up, and you're like, they're just not getting better. And you'd say, okay, maybe I'm going to go in and do a plantar fasciotomy. Shockwave therapy, perfect thing to come in right then. I have not operated on a plantar fascia in years.
Hmm. It's interesting. So you keep mentioning regenerative, and I think that's kind of the key difference here when we're talking about this is that there is some physiological transformation, whether it's in the tenocytes or the ligament, and it's actually kind of healing somewhat
Right.
versus a steroid injection that just provides some temporary relief. I've certainly given my fair share of heel steroid injections, and some people go away and they don't come back for years, and some people come back every 3 months, which we know according to literature is the efficacious, or the, I don't know the right word, the length of time that the steroid medicine is effective for, and then it wears off after that time, and it's just boom, coming back. You're in this cycle. So trying something different to kind of break that cycle is an interesting alternative to steroid injections.
Absolutely. I always tell my patients the body has forgotten about this area and you're kind of waking it up. And so
Uh-huh.
the only thing that I tell my patients not to do afterwards is ice or take any NSAIDs.
Okay.
And so we stop that for as long as they can.
Because you want
And
inflammation.
yep, yep, exactly. So you want the inflammatory process to happen.
Uh-huh.
That doesn't necessarily cause increased pain or anything like that, but you don't want to block that inflammatory process.
Mhm.
And it's very easy to do, low learning curve, and it's time efficient as well. It doesn't take very long. So from a practice management point of view, it's an investment that you make into your practice and your patient's health. And there's significant improvement and practice management benefit as well.
So how do you actually perform the procedure, if you want to call it that? How do you actually perform it? Obviously, it's a machine. And then how long are you doing it for? Are you kind of moving it around? Are you holding it
Yeah.
in place? What are you doing?
So the machine that I have, I first kind of relax the muscles with the Theragun or something like
Yeah.
that initially, just to loosen up the muscles. And then depending on how deep you want to go with the sound waves, you pick the right head for the machine and you put that on. And
Okay.
we initially do a large area and then we focus it more on the smaller area. I usually do about 2,000 pulses, and then switch the head over. So for a total of 6,000 pulses, and that takes about 15 minutes at the most, I would say. And then so if I'm doing the plantar fascia, I also do the bottom of the plantar fascia and along the Achilles tendon as well, as we know that it's all connected, and
Uh-huh.
sometimes all the way up to the calf. You just need to you need to know which head to use. There's ones that go over bony prominences when you're doing the perineal tendon, for example, or areas you can go deeper, such as the plantar fascia. I've even had good results with neuromas as
Mm.
well. I get a lot of second opinions where some doctors just keep injecting and keep injecting and keep injecting. And what have they created? Scar tissue. They've created scar tissue in the area, and now they have this kind of chronic pain there, or you need to keep injecting it. There's little heads that they use on the hand so that you can
Uh-huh.
use along the neuroma site as well.
How much are you moving it around as you're doing this? Are you like holding it in position while it's delivering the pulses, or are you kind of like slowly moving it? I've never used it before.
Yeah, so I slowly move it along everywhere with a lot of pressure, but I do mark the sensitive spots and really hang out there as well. And what we do is between the three treatments that I do, like week 1, 2, and 3, we up the intensity each time. And
Mhm.
the first time the patients are like, oh, this is weird, this is uncomfortable. But by the second or third time, they significantly, can tolerate it. So you
Mm.
can up it. And then there's some patients that studies show that you need about 3 to 5 treatments. I've seen significant improvement around 3, sometimes 4. So, and then I also have the patients that have terrible retrocalcaneal spurs. Okay. And we know that unless we operate on that spur, their Achilles tendonitis is not going to get better, but
Mhm.
they're not good surgical candidates, either due to weight or other comorbidities. So I've had those patients come back sometimes, because they think that it's the only thing that's helped them. So they'd come back for another treatment, because it's really important to know the true etiology of what your patient's coming in for. So if you're trying to tell a patient that it's going to be 100% better and they have a huge bone spur in the back of their calc, that's not true. So if you tell them, okay, this may help you 60 to 70%,
Right.
nothing else is, you really have to set the expectations as well.
Yeah, makes sense. So I think one of the thoughts about it is that it's painful, but you're saying that it's more of a discomfort. You're not using any local anesthetic when you're doing this.
Not. There is shockwave where the patient can be put under anesthetic or general. And from what I understand, the VA uses it, and it's the one that you have to anesthetize. But
Mm.
there are other ones you can use in your office, like the radial machine, that is definitely less discomfort, and it's very sleek. It's a small handpiece,
Mhm.
and very easy to use.
As far as cost to the patient, doesn't have to be exact, but roughly what are the costs to the patient? Is it per session or is it per like overall treatment, like course?
Yeah. So what I always emphasize is do a package of 3, and
Mhm.
it has to be 3. I have not seen improvement after just one. It
Mhm.
has to be to build up to where the patient is going to get maximal benefit. So I've seen prices vary from like 600 to over $1,000, depending on what region of the country that you live in.
Mhm.
And then if patients need additional treatments, then I'll break it off into per session.
Okay. So speaking more of regenerative medicine, is there anything else that you would characterize as regenerative medicine that you do aside from
Yeah.
shockwave
So
therapy?
PRP as well. When I was in residency, it was, used all the time in the
Hmm.
OR and things like that. And that's how we lost the coverage for that. But I do think that there's also a time and place for PRP still.
Hmm.
I've been using it less since I've been using shockwave. But again, I feel like we should be educated on all of this, right? So you're offering your patients, different modalities, and as well as ultrasound technique, right? That's not really a form of regenerative medicine, but it will help when you're giving the PRP. I always do it under ultrasound guidance. But yeah, I did like an ultrasound lab, I think maybe here or there in podiatry school, maybe. But
Yeah, it's
I
pretty rare.
obviously don't really remember it. And in residency, I think I honestly maybe a couple of times, but I really feel like that's a skill that we should be better at, not for reimbursement's sake, but it helps if you pair that with regenerative medicine, especially if you're doing amnion injections or stem cells. I know that's very controversial now, or PRP. So those are the three big ones, that I introduce in my practice.
I think ultrasound is a extremely underutilized modality and skill that I completely agree with you. We are undertrained. We do not get exposed to it enough. I don't know that I've ever been exposed to it. And I think that the reason is that there's a bit of a steep learning curve. When you start learning how to utilize ultrasound, there's a lot that goes into that. And if you were fully trained on how to use it, the benefits of it to me are significant. Whether it's
Mhm.
you're using it to guide an injection, fine. Like anyone, my my son who's 10 can hit the plantar fascia without trying too hard,
Right.
right? That's easy. We
Exactly.
don't really need an ultrasound guided injection
Yeah.
in the plantar fascia. But if we're going to hit maybe a midfoot joint or something, that makes some sense to try to use ultrasound to guide you because it's easy and it's available. It's in your office. But also diagnostically, if you got very, very good at ultrasound, maybe you don't need an MRI, or maybe the MRI is you use the ultrasound in a way that says, yeah, there's something going on. I can't really tell
Yeah.
100%, but we're definitely going to get the MRI because something's weird here. Or, it looks pretty normal. I don't know that the MRI is going to be terribly helpful for us, but I think
Mhm.
it's severely underutilized.
Absolutely. And, even to measure the thickness of the plantar fascia, studies show that the plantar fascia thickens and you can tell how chronic it is. But you're right. Like it's a steep learning curve. And now the devices are so streamlined. Like I have to
Mhm.
tell you, we attach it to our iPad.
Yeah.
Like how cool, and you can show the patient right there. And then you can always order the confirmatory MRI if needed or ultrasound
Right.
if needed. But I don't know, I'm getting a lot of MRI denials now, and you have to
Mhm.
try this and try that. Trying to find an ultrasound place to send your patient to is really difficult.
Yeah.
Especially even in our area that we have multiple imaging centers. Some patients just don't do ultrasound at all, or they're not good at it either, because they don't do enough of them.
Mhm.
So if we could really master that, I think it would help because that's a big difference between Canadian medicine and American medicine. It's we use a lot of they use a lot of ultrasound there, ton of
Hmm.
ultrasound.
Interesting.
That even my dad's orthopedist, and they'll send you for diagnostic ultrasound, and it's less radiation for the patient as well.
Mhm.
So this is kind of why I always talk about regenerative medicine, ultrasound, and all these different things. I'm really involved with the podiatry community in general, and I love surgery. I operate every week. I am a pretty, as I said, well-rounded podiatrist, but we're always like surgery, 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 surgery. But all of these different things make us better clinicians, better physicians. So I really think it should be emphasized.
Yeah. Super, super slick that it hooks up to the iPad.
How
Although for
cool.
for me, that's probably not fantastic because then the patient can ask me, "What's that? What's that?" I'm
Yeah.
like, "I
Yeah.
have no idea.
Yeah.
That's a black
Right.
squiggle right there. You see that black squiggle?
Yeah.
That's not good. You don't want that black squiggle." I'd have no
Exactly. And
idea
that's
what I
why
was
you're
saying.
right. You need to, and you have to seek out there's a lot of regenerative therapy conferences out there. It doesn't all pertain to us, but you'd be surprised how much they use it in the lower extremity, like sports medicine, ortho, because
Mhm.
we treat a hard area, a really hard area, and everybody wants the most conservative treatment first. So you have to seek out the education.
Absolutely. Let's transition to your role and involvement with the APMA. You are the chair of the communications committee, and are you the chair of the education committee or just on the
Nope,
education
that's
committee?
Dr. Pat Burns, but I'm
I
on the
know him.
education committee. Yep. So I've been very involved. I'm also president-elect for our local chapter, and whenever I get the chance, I advocate for people to become involved, and it is so important. Our profession is really where it is because people gave up their time to expand our scope to get us into hospitals. These people are retiring. And I'm telling you, there are not enough people behind them. Okay.
Mhm.
Everybody is spending time on, everyone's busy. I have 3 kids, right?
Yeah.
1, 3, and 8.
Hmm.
And I'm not super mom. I choose to advocate for the profession because we're also a podiatry family, right? So we're dependent on podiatry and we don't want to lose what we have.
Sure.
So being involved with APMA, MPMA has really, really kind of shaped my career and shaped what I want to do with it as well. Because people, it's all unpaid, right? It's volunteering your time,
Right.
but the profession has given back to us and we have to give back to the profession. And the other thing that people don't understand is how important advocacy is, right? Like, okay, cool, right? I love that we have a great scope of practice for surgery and all of that. And we have the newest surgical equipment and we go to these labs and are trained and stuff like that. What happens if we're just not getting reimbursed enough for that? What happens if we are cut out of a portion of, I don't know, Medicare, Medicaid? Every state is different
Mhm.
and we need to advocate to change that, and APMA advocates for you. And okay, even if you don't have the time, donating would help. Advocating at grassroots in your state also helps as well. So I really think that our generation just is not getting that.
Yeah. It's difficult. I agree with you 100%. If the APMA is not advocating for us, who will? Right. And so it's super important. And I don't think people understand that. So, anyone listening, the APMA is the kind of body who looks out for podiatry, essentially.
Yeah.
Um,
And
and
this weekend is the House of Delegates that is coming up. So when people complain about, I don't know, residencies, board certification, student enrollment, the House of Delegates is where all of the decisions are made. So there are representatives from each state and they vote on these things. If they're going to change how residencies are, or they're going to allow someone to do that, or they're going to change something going on with board certification. This is where things change. And I love the people that have been there for years and years and years. Okay. They've really made waves, but it's time for other people to fill those seats. Sometimes we run into problems that people don't want to give up their seat, but other times there's no young people to fill them, so they have to stay in the seat. So it's two different scenarios that are going on in the profession as well. And
uh,
we know, both of us, it's a great profession, and we need to, really tout our horn with that. And that's what I do as chair of communications too. As you say, you're like, oh, you're everywhere. I've had a lot of really good media spots.
mhm.
And it's great to be the medical expert along with other orthopedic surgeons, for example. I was doing an article for CNN. It was me and 2 other orthopedic surgeons in 3 different articles, right? Um, we are the foot and ankle expert, especially when it comes to things like shoes and all those different things. And so people are like, oh, well, you're talking about shoes again and things like that. Hey, it's important. And
Mhm.
when you get the patient in the door because you are the expert in that area, then they realize, oh, wait, I ruptured my Achilles. Wait, you can fix that? Right.
Mhm.
And we want to think that the public perception isn't like that. In some
Yeah.
areas, it is. Right.
But
So I
I
really,
still
really
get
try to get that out there.
I still get people every day who come in for an ingrown nail or something like, how'd you get into feet? And I was like, well, I like sports medicine. I like the
Yeah.
trauma. And they're like, what? You do what? It's like, you're sitting in my office and just like patient after patient. They just don't know. And that's an uphill battle. I think it's getting better. I know it's getting better because
Yeah.
that's fewer and fewer people. Usually younger people understand that. It's usually the older people who just,
Yeah.
generationally, maybe our profession was different. So how could they know that things have changed with the times? But yeah, it happens all the time where people don't really understand the full extent of what it is that we do.
Totally, and especially like pediatrics as well, right? They're like, "Oh, I can bring my son in," you know? It's like, "Yeah, yeah," and that's why, I
Does he
don't
have
know if
feet?
you've heard.
Does
Yeah,
your son have
exactly.
feet?
My recent, rant on Crocs, for example, right? But I've seen a ton of injuries, and I see a lot of peds in my practice,
Yeah.
and that's a very hot topic that they really, really. That's where podiatrists were highlighted about it, like quotes in New York Times and things like that. So
Mhm.
just getting in there and really advertising what we do.
So, for someone who did want to get involved, say someone's listening to this, the tens of people listening to this right now want to get involved, and they think that, hey, I want to be involved. How could I do that? What would be the best way for them to get involved in whatever organization they might want to be involved in, whether it be the APMA or something else?
Yeah, absolutely. So, number one is to find someone that is involved in the organization, right? Reach out to them and start little, right? And so, just come to a meeting. That would be step one. Just support by coming to a meeting and seeing if it's for you. And if you like it and you like what you see, then try to get involved in committees. And the committee commitment is not very involved in, so it's depending on what committee you're on, and that is when you kind of get your foot in the door and realize, do you want to do more or where do you want to go with it? So, um, as you said, many different organizations. I was on the board of ABPM. I'm with Podiatry Today, AAWP. I don't hold a position with them, but really involved with lecturing and things like that. There's so many different organizations that it gets overwhelming, right?
Mhm.
Because like you're like, well, I can't be with everything, but you're into sports medicine. Join the sports medicine group, and then I anytime I did not want to go to a meeting, like, I'm like, oh man, like, there's so much stuff going on this weekend. I've always benefited from it. Okay.
Mhm.
So it's not only just giving back. A lot of the time, your practice benefits, you benefit from it. That's a bonus as well, right? So you're not just doing it to help the profession. It always comes full circle.
Mhm.
You never know who you're going to meet and where.
It is strange. You might meet your spouse in podiatry school.
Exactly. Right.
You never
Exactly.
know.
You never know.
What would be some advice that you have for young practitioners that are kind of going through the things that you and I have already gone through, the school and the residency? Maybe they're feeling a little kind of like burnt out or stressed out, or maybe they didn't do so hot on a test, or maybe they didn't match into residency. What advice would you give for some young practitioners that are kind of not so optimistic about podiatry?
Yeah. And whenever I go to speak at the schools on behalf of an organization and things like that, I always start off by saying that I failed my board exams. I failed them pretty badly. I just came from
Fairly common.
Canada. I had, no idea what was going on, sort of thing. And I was like, that's it. My career's over. I'm like, why did I come to this country? Like, this is terrible. Don't let that one failure set you back,
Mhm.
and don't let anyone tell you that you are not good enough. That's another thing that, oh, well, you can't do that. Oh, if you want children, you can't do that, right? You cannot have it all, work life balance, but you'll find your rhythm and you'll find what your passion is, and podiatry is an awesome profession to do that. So I that's my advice is always go to that meeting or go to that event or that networking event, even if you don't want to go to, because again, you're always going to meet someone. And two is don't let one failure set you back, because I've had plenty of failures in many different things, and I think I'm doing fairly well for myself. 13 years into practice.
Absolutely.
And then 3 is, especially in residency, when you feel like, it's not going to work out, and I'm sure you hear this all the time, but it is the best time to learn all these different things, right?
Mhm.
You don't have to wait to be in practice to learn about regenerative medicine and ultrasound. I remember in my residency, I felt like I was not getting enough scopes. We sought a rotation where literally my last 2 months of residency, I scrubbed with this guy until I did like ton of scoping.
Mhm.
And so you could also change what you think can't be changed. If you just speak up, I hate that fear that people have, you don't want to be reprimanded or you think that it's not going to happen, but
Mhm.
always advocate for yourself. Always. No one else is going to do it for you. And I have had to do that multiple times in my career. I have been the youngest person, the only female of color. I have really faced all of those things. And it's only made me stronger.
Absolutely. I think those are fantastic words, and I wholeheartedly agree with you. So, thank you so much for joining me tonight and spending some time and educating everyone on all the things that you do and why you are everywhere and how you are able to do all those things.
Absolutely. Thank you so much for having me. You do a great job with this podcast, and I love the positive light that we give to podiatry.
Thank you. Appreciate that. So, super excited to have you on tonight, and thank you for your time.
You're very welcome.
Thanks, everybody, for joining us on this episode of Paw Patrol with your host, Dr. Jeff Dikis. We'll see you next time.
Disclaimer. Opinions expressed are those of the content creators and do not represent any employer or entity. The information shared is for informational purposes only and should not be construed as medical advice or used in any legal capacity, including establishing standards of care. All efforts have been made to comply with HIPAA regulations. No guarantees are made regarding the accuracy of statements or opinions provided. Interaction with the podcast does not establish a doctor-patient relationship. Please enjoy this podcast responsibly.